So the first speaker is Dr. Craig Dale, and while he pulls up his slides, I'm just going to give a brief introduction. So Craig Dale is an assistant professor at the Lawrence S. Bloomberg Faculty of Nursing, University of Toronto, scientist in the Tory Trauma Program at Sunnybrook Health Sciences Centre, and holds an appointment as a scientist in the University of Toronto Centre for the Study of Pain. His research explores fundamental care for critically ill patients, including pain management, hygiene, and communication. He employs qualitative and mixed methods approaches in his research. And we're thrilled to have him as an author as part of this special issue.
Thank you very much for the introduction, Perry, and it's a pleasure to be here and to join so many people. I'm talking about helping people to talk about pain, and I'll be speaking specifically to elicitation interviews with critically ill adults. Oops, sorry. I first want to acknowledge the Canadian Journal of Pain, Joel Katz, and the co-editors, Fiona and Perry, for this special issue and the important contribution this makes. I'd also like to thank my co-authors for the study published in the edition and the students who worked on this, and also the institutions who support my research. Just a brief note that some of the photographic images that are embedded in my presentation are somewhat graphic, and some people might find them disturbing or uncomfortable, so please note that they're coming. Some of the objectives of my presentation are to introduce the problem of procedural pain in the intensive care unit. And I want to describe a process called elicitation to enhance interviewing with seriously ill patients in this circumstance. And I'll provide some reflections on this approach in pain inquiry. So to those unfamiliar with intensive care, also known as critical care, it's an interprofessional specialty dedicated to comprehensive management of hospitalized patients having or at risk of developing acute life-threatening organ dysfunction. And there's an array of technologies in the intensive care unit, but mechanical ventilation delivered through a breathing tube is really the core treatment modality. Worldwide, we think there's about 13 to 20 million people admitted to ICUs each year, and in Canada, we have about 250,000 admissions. Treatment with mechanical ventilation averages about 4 days in duration for adult patients in Canada. However, there's a growing group of patients characterized by advanced age and complex comorbidity who experience prolonged mechanical ventilation defined as about 21 days or longer. And this group occupies about 11% of our ICU beds, and we're really concerned about the quality of care they receive. Oral placement of breathing tubes for mechanical ventilation requires attention to oral health. And prevalence work conducted by my research team has identified about 2 oral devices on average and up to 4 devices maximum in the mouths of these patients. So within hours of mechanical ventilation, the oral physiology of the intensive care patient begins to change with a decrease in saliva and production and flow. The loss of lubricating, anti-inflammatory, and antibacterial properties of saliva mean the tissues become very dry. Mucosal lesions can erupt over time, and bacteria in the form of gram-negatives can proliferate. And aspiration of this bacteria into the lower areas can precipitate pneumonia. And this is a big focus of our work in this setting. But in response to these oral health changes and risk of oral systemic infection, evidence-based guidelines strongly recommend frequent preventative oral care procedures, including toothbrushing, application of oral moisturizers, placement of topical oral antibiotics in the mouth, and antimicrobials, and suctioning of debris. So the recommendation for frequent procedures in the mouth turns our attention to knowledge of procedural pain in the ICU. And we know from prospective descriptive studies that the presence of an oral endotracheal tube or a breathing tube is associated with discomfort at rest, and that routine procedures such as tracheal suctioning, position changes, and line removal cause pain. And one study suggests that incidence of pain is as frequent as 50% in medical surgical ICU patients and 80% during common procedures. The important takeaway from this body of research is that unmanaged pain contributes to a range of deleterious outcomes, including anxiety, depression, delirium, post-traumatic stress disorder, and chronic pain. And incapacities associated with placement of a breathing tube means that patients are unable to verbally self-report pain, which is a gold standard. And a recent ICU paradigm shift to light sedation, also called analgesic sedation, suggests more patients will be awake and aware of pain, but still unable to self-report because of a breathing tube. And in my work, I've become quite curious about the absence of oral procedures in the list of potentially painful procedures in the literature. And of course, my prior research has shown that there's a lot of pain behaviors or behaviors that are indicative of pain in patients during oral care. And I wanted to know what patients recollected about this kind of care and what the recommendations are around it. So I proceeded with qualitative work. And when I sat down to design this qualitative study, I realized it might be beneficial to utilize something innovative called elicitation during patient interviews. Objective measures of pain don't really help us understand how individuals make meaning of painful experiences, hence qualitative research can be helpful. However, asking exploratory questions about subjects like pain can be really frustrating, in part because patients can find it really difficult to find adequate words to describe certain kinds of pain experiences, particularly, and of course, some patients might actually be reluctant to share those experiences, particularly with somebody they don't know, meaning an interviewer. So elicitation techniques are a category of research tasks that use visual, verbal, or written stimuli during an interview. And this can include presentation of photos, documents, and even objects such as oral care tools that you see here on the screen. And in fact, these are the tools I brought with me to the bedside when I was interviewing patients in the hospital. As you can see, or imagine as a strategy to overcome barriers to talking about pain, elicitation can improve recall or access of tacit insights by participants about events or circumstances, and therefore produce richer data when compared to standard interviews. Now, focusing on objects may relieve a kind of nervousness around perceived interrogative nature of qualitative interviewing. And elicitation affords participants kind of an active role rather than a passive role in directing the interview discussions. And this was really exciting and important to me. In terms of qualitative methodology, we conducted a qualitative descriptive study, which is an approach often used by clinician researchers to address clinical problems. This gives it a post-positivist and pragmatic philosophical orientation. And researchers using this approach often want to improve practice. We purposefully recruited ICU survivors who had recall of the breathing tube and being in the ICU itself. And we collected elicitation, or rather data collection comprised elicitation interviews within 7 days of ICU discharge on the ward. And we use this time point as we anticipate patients would be sufficiently recovered to carry on a conversation while still having relatively fresh recollections to share. Moreover, we thought they would be potentially better situated to speak freely about their ICU care experiences outside that setting. We use content analysis methods, first directed to understanding the pain descriptors, how patients were actually talking, whether they found these procedures painful, what words they used, and the meanings they ascribed to those experiences. And we subsequently generated themes that link together these experiences. We recruited 33 adult ICU survivors, most being male and over the age of 50. Over half recalled procedure oral pain, and almost 90% recalled generalized oral discomfort at all times. And we, from the narratives, developed 4 themes, which I'll explore in the next slide. So the first theme, almost all participants who describe pain and discomfort in their experiences, and these discomforting sensations evoked emotional states for them, such as fear, anguish, worry, and even panic. For example, one participant stated, "You don't want them to do it. It hurt," meaning inserting instruments inside the mouth. For the second theme, a prominently recognized source or antecedent to pain was oral health deterioration during ICU treatment. In this case, dry oral tissues made a very painful context for routine oral interventions. One participant shared, "It was so dry, the corners of my lips cracked and it hurt to move my mouth." In the third theme, several participants spoke about unrecognized suffering related to pain being misunderstood or misinterpreted by clinicians as agitation. For example, in trying to stop oral care procedures and garner attention of clinicians to pain, they often reached up, and clinicians recalled being physically restrained in response to these gestures or forms of communication. So rather than inquiring about pain or discomfort, they recalled clinicians telling them, don't do that, meaning don't reach up and don't try and get my attention. And so these were very difficult and dehumanizing experiences as they characterized them, particularly because care was delivered without attention to pain management. In the fourth theme, participants spoke about the importance of professional care to prevent pain and suffering. For example, patients recalled surprising omissions. In looking at the devices, they saw toothbrushes and they said that they'd never had an experience in the ICU of somebody brushing their teeth, and they saw these emissions as contributing to painful conditions in their mouth, and they also saw these emissions as uncaring and also dehumanizing. So in reflection, I can say I found elicitation during interviews to be far more powerful than anticipated, because I've done lots of interviewing without this. And I retrieved unexpected findings, key contextual insights, and knowledge about the role of oral pain in the ICU patient experience that really changed what I understand. And I have to admit that I would not have designed interview questions to target many of the issues that spontaneously arose in response to the presence of these tools and some reflections on them. Insight drawn from these kinds of interviews provide rich targets for practice innovation. For example, patients recalled, low cost, or rather they suggested low cost non-pharmacological practice improvements, including special guidance and pacing during potential painful procedures and increased frequency of care to prevent painful oral health deterioration. And in fact, the lack of attention to pain draws attention to the importance of structured pain appraisal using validated behavioral pain tools in nonverbal populations. Finally, elicitation interviews offer an expert role for patients, and this is really well aligned with the ethos of patient-oriented research in which patients' needs and concerns are given equal consideration. In addition to identifying patient recollections and recommendations for care improvement, I would argue that elicitation can play an important role in rehumanizing healthcare by illuminating events or practices that contribute to pain and suffering. And these issues can be taken up in clinical practice guidelines to improve clinicians' awareness and practice. So I'd like to thank the patient participants who are extraordinary in this study, as well as the ICU clinicians at Sunnybrook Health Sciences Centre who facilitated this work. And so thanks very much.